Welcome to today's lecture in the year-long lecture series on race and regulation, organized by the Penn Program on Regulation. I'm Kerry Colonisi, the director of the Penn Program on Regulation and a professor at the University of Pennsylvania Law School. This lecture series on race and regulation focuses on the most important task for every society, ensuring equal justice and dignity and respect to all people. Today's lecture will focus on vaccination equity by design, with lessons for designing equitable transportation, housing, and education policy. Our speaker, Olatunde Johnson, is the Jerome B. Sherman Professor of Law at Columbia Law School. An award-winning teacher, Professor Johnson is one of the nation's leading scholars on civil rights law, anti-discrimination, regulation, fair housing, and legislation. A graduate of Stanford Law School, she served as a clerk on the DC Circuit Court of Appeals and in the chambers U.S. Supreme Court. She's also worked as a lawyer both for the NAACP Legal Defense Fund and with the ACLU, and has served as counsel to Senator Kennedy on the Senate Judiciary Committee. Today's lecture is co-sponsored by the Leonard Davis Institute of Health Economics, as well as our partner for the entire series, the University of Pennsylvania Law School's Office on Equity and Inclusion. At the conclusion of Professor Johnson's lecture, we will have an opportunity for questions from the audience. To submit a question, please simply click on the Q&A button at the bottom of your Zoom screen. I will then be able to see your questions and ask as many of them as time permits of Professor Johnson. And now, without any further delay, it is my distinct honor and privilege to turn the screen and the microphone over to Professor Johnson to speak on vaccine equity by design and lessons for equity on other important policy matters as well. Professor Johnson?
So good evening. I think it's wonderful that you're having this series. People don't always connect questions of race and regulation, but that's been at the core of a lot of what I've been thinking about as an academic and as a lawyer. I'm going to have some slides, and I'm actually going to begin in the reverse, which is with the other categories, with transit and housing, and then move into vaccination. So my talk today does stem from a paper that I co-wrote with Kristen Underhill, who is now at Cornell Law School. And we were interested in the question of how to advance equity in the distribution of COVID vaccines. We wrote this pretty early in the pandemic. The paper, we believe, has relevance for vaccine distribution, but also for the design and programs of administrative agencies far beyond vaccines. So I said that before getting to the heart of the paper that I wanted to start with an origin story, which is really my origin story, but is also, I think, an origin of a lot of the ideas that undergird the paper. For me, it was not inevitable that I would be talking about vaccines or health. So I wanted to just provide some context for how I came to this project and what's meaningful to me about the intersection of administrative law, civil rights, and racial justice. So the story starts actually with the LA bus riders case. In the mid-1990s, Los Angeles became the location of really bold, innovative litigation to address racial inequities in the design and operation of public transit. And as many of you know, LA is a famously car-dependent city, designed with an interlocking array of highways. I know that to Los Angelinos, it's very crucial to their self-conception, but it also shapes segregation, air quality, economic opportunity in very racialized ways in Los Angeles. And it's not just distinct to Los Angeles. This is a story that replays itself across a lot of metropolitan areas. Public transit has historically been less prioritized in Los Angeles and maybe less prioritized than in some major cities. The immediate impetus for a lawsuit that I ended up working on in the mid-1990s was the LA Transit Authority's action. They decided to develop a high-speed rail project that would serve mostly suburban residents and bring them to a downtown that was beginning to be revitalized. At the same time, buses that serve mostly working class people of color continued to be pretty poorly funded. So the Transit Authority decided to raise bus fares, even as money was being poured into high-speed rail. So there were several really distinct things about this case. First, it relied on Title VI of the 1964 Civil Rights Act to challenge the decision to raise fares and the broad issue of discriminatory subsidies. Title VI applies to all entities that receive federal funds, and this transit project, both the high-speed rail and the buses, were funded with state and local funds and with federal funds. Title VI prohibits discrimination, intentional discrimination, but also disparate impact. And significantly at the time, it allowed you to bring suit on both disparate impact and intentional discrimination claims. At that time, there hadn't been that much litigation under Title VI disparate impact, so that was something that was innovative. Most of the litigation that had been brought under disparate impact involved schools. And what's interesting about Title VI is that it is not just a statute about litigation and about private action. It's about the role of the federal government in advancing an idea of equality. It's about using administrative power to enforce Brown versus Board of Education. That was the origin of it. They wanted to spur Southern school districts to desegregate. And the innovation in this case was to use it in the domain of transportation and also, as I said, to litigate the matter. So Title VI and federal spending were the hook, but this is not just a legal device to permit this claim. The case really was centrally about the role of federal spending in subsidizing some communities instead of others, in giving racial inequity a spatial dimension. So here, in this case, you had federal funds that were subsidizing decisions about whose communities were worthy of transit investment. And those transit decisions had tremendous impact on economic access to jobs, obviously connecting to education, and other resources, as well as air quality, as I've mentioned. So through this lawsuit, these communities were really highlighting the impact of this transit decision on their communities. I think now we understand more the connection between federal spending and spatial inequality and racial inequality. And this is the cover of Richard Rothstein's recent book, The Color of Law. At the time, we had a predecessor book by Douglas Massey and Nancy Denton called American Apartheid. On the cover of The Color of Law, you see the famous red line maps. And they really tell a story about some of the connections between federal spending and racial inequality. I am pausing just a moment. Yeah, there's a final note about the case that we could talk about more, which is that the case was brought by the NAACP Legal Defense Fund. And one of the pieces that was innovative about it is that they represented a multiracial group of organizations headed by the Bus Riders Union. I think it's key to mention that because this was a group that it was working at the intersection of community development, transit, labor, and environmental justice. It's also something we can talk about later if we have time, which is that it really is through the work of social movements that you activate and give meaning to a lot of these regulations. We often think about regulation as a kind of technocratic endeavor. I say there's a democratic aspect to it that comes when groups like the bus riders unions bring litigation and also bring administrative complaints. So I knew about this case because I was a law student working for the semester at the NAACP Legal Defense Fund in Los Angeles, and I eventually became a lawyer in the New York office at LDF. And it really made me interested in how civil rights statutes could help address this question of spatial inequality, but also about the administrative law aspect of this and the role of federal spending. So we can fast forward to 2020, and let's see if I can actually fast forward. COVID hits. Like many of you, we were all, I think, stunned and shocked, grieving. I spent most of the pandemic on my stoop in Harlem, and I feel lucky to live in Harlem. I live right off Frederick Douglass Boulevard, which is kind of an example of his composite nation with all of its challenges. It's at the crossroads of race and class. It's taking on the challenges of being a neighborhood, an inclusive neighborhood, but there are expensive brownstones next to Section 8 and public housing. There's lots of economic and racial diversity, but also a lot of inequality. And I could see very different effects of COVID-19 in my neighborhood, and certainly in the city beyond my neighborhood. Many of the people I knew or that my kids knew left the city. I was perfectly able to socially distance in the city. I didn't have to work in person. I didn't have to deliver anything. And as the data on the racial and economic impact came out in New York and throughout the country, we started to see this data on racial and ethnic disparity and on economic disparity and who was most affected. And so the slide has some of that data. In the paper, we have a lot more about Black and Latino people across the country being 2 to 3 times more likely to be hospitalized, more than twice as likely to die from COVID-19 as white non-Hispanic people. There was also a spatial dimension to it and an occupational dimension. This is also, it's hard to see it all, but it's a chart about states and racial disproportion in the states in which the impact of COVID was most racially disproportionate. Interesting, and these are sort of replayed across different metropolitan areas, the spatial dimension of it, some neighborhoods more hard hit than others in terms of positive cases, in terms of deaths, in terms of severe disease, but also certain sectors, certain employment sectors. And one of these charts, which is from Columbia University's Public Health School, overlays service workers. So there was a real dimension of occupation and also a neighborhood dimension that sometimes wasn't well captured by just looking at questions of racial disparity. So I was curious then when the vaccine rolled out to really see who would have access first and about the administrative choices that would be made and whether they would reflect some of these spatial and occupational and racial differences. So when the vaccines rolled out, I mean, what we see is that there are racial disparities, especially early on in who had access to the vaccine. I have much more detailed data that's in the paper, but essentially what we saw were that Black, Latino, and Native American communities in the initial stages, there were racial disparities overall in the uptake or the receipt of vaccine overall. And then also relative to the impact of COVID-19 in their communities, whether measured by the disease rate or death rates, and also within priority groups. I mean, some of the hardest hit communities were actually Black, Latino, and Asian healthcare workers, and they had less early access to the vaccine. And even though there's a narrative of certain communities are mistrustful and there's a really deep history of mistrust, even relative to express willingness to take the vaccine. So in our paper, we really begin with the notion of an inverse equity hypothesis. This is a theory from outside my specialty, which is it's my collaborator, Kristen Underhill's specialty, which is the notion that given the fact that there are existing healthcare inequalities in access to healthcare resources, anytime you have a new health technology, it tends to amplify that inequality, at least initially. So researchers have studied innovations as varied as heart surgeries, immunizations, HIV treatments, hospital births, and have found this. And so the idea is that early on in the diffusion of a new technology, such as a vaccine, wealthy people are early adopters. And then as diffusion expands, demand and access by middle income and poor people becomes greater. But that some of these delays tend to persist even over time. And so we were interested in the fact that this is a theory that is known to public health researchers, and would it be anticipated? So the idea is vaccine and other innovations are going to aggravate inequality in very predictable ways. So racial disparities in healthcare are pervasive. They're very well documented. We know all the reasons, or a lot of the reasons around these disparities. They're socioeconomic. They are about unequal insurance availability. They have a spatial dimension about the accessibility of healthcare facilities and providers. And then there's also a role of explicit and implicit bias among care providers. So given these underlying disparities and the existence of justified medical mistrust, this inverse equity hypothesis would predict that there'd be disparities in who had access to the vaccine. And so in the early days of the vaccine, when we were writing, this was in 2021, we saw this to be true. So despite the fact that individuals and communities of color were harder hit, they had less access to the vaccine. And so you could see this as inevitable, right? But another approach that we think is fairer in terms of sort of how health researchers and providers think about fairness, but also consistent with civil rights norms, would be to choose design mechanisms and guidance that really alleviate those disparities. And we saw that the CDC in its initial guidelines did make some key choices that likely made the vaccine more accessible on the basis of race and class. So one was to make sure that the vaccine was accessible to people who were uninsured. That was a design choice, that nobody had to pay for the vaccine up front. So being able to pay was not a barrier. Another, I think, arguably choice that decreased disparity that you could say was that it wasn't done through the primary care providers. That could cut both ways, but that would at least an attempt to make access more widespread. But other design choices contributed to disparity or really failed to mitigate disparity. And so those are some of the things that we focus on. For purposes of this talk, I just want to highlight what I have in the top, which is the gaps in the CDC guidance. I'll say briefly that many of us could see with our own eyes, even without having to consult detailed research documents, how some of the decisions that were made at the state and local level would generate different kinds of disparities. So one was relying on sort of opt-in and demand, right? That people had to present themselves. So people who are most vulnerable sometimes are reluctant to do that for a range of reasons. The reliance on internet web-based scheduling was kind of a famous moment. There are lots of accounts of people trying to help other people schedule who didn't have access to the internet or couldn't use the technology. Mass vaccination sites, I mean, that we really see the benefits of that because it allowed you to schedule people quickly, but the downside was that they were often inaccessible by transit. So could the CDC have done anything about it? And we see gaps in some of the decisions that were made by the federal regulatory agency. Their prioritization guidelines excluded certain high-risk categories. So they relied on broad categories of age and work status and medical risk for initial prioritization, which is important. But it also excluded some work categories that were very high risk. And a key thing it such as delivery workers and service workers and other frontline workers in the initial stages. It also excluded additional ways of measuring social health vulnerability that might have diminished racial and ethnic impact. For instance, the initial guidelines chose not to prioritize communities at high risk or who had suffered high rates of COVID-19 infection and adverse consequences. And so this is not just a sort of hindsight observation. This was just a recommendation that was made at the time. And I don't know all the reasons behind the competing considerations, but that was an area that was chosen not to be put in as a priority category. So we, in the paper, lay out some ways in which one might think about mitigating these kinds of disparities going forward. And some of these suggestions that we make are things that we believe the CDC could have adopted at the time, or HHS, Health and Human Services, but they also have implications more broadly for the design of any kind of federal program. So the first thing we really emphasize are broader use of equality directives. This is something that I have written about in other contexts, specifically around transit and housing. So there are wonderful models of this in transit, urged on by the bus riders union, which is the group that brought the LA transit case. They did a lot of administrative advocacy, and it was by necessity, because in 2001, the Supreme Court held that there was no private right of action to enforce the disparate impact provisions of Title VI. And so administrative advocacy became the way to make those disparate impact provisions meaningful. And they and internal forces in DOT really push for transit equity assessments and front end assessments to be a mode of dealing and anticipating and preventing disparities, encouraging the participation of groups in the design of public transit and key transit decisions. It also applies to highways. So in the context of COVID, affirmative guidance from HHS and the Department of Justice and CDC might have directed states to avoid COVID-19 vaccine distribution mechanisms that exacerbate racial and ethnic inequities, while also instructing them on how to improve access. So this could include things like advising grant recipients to locate vaccination sites in communities most affected by the pandemic, decentralizing distribution, providing transportation, allowing walk-in or telephone scheduling as an alternative to inter-base registration, partnering with community groups. So we suggest a few strategies. A second piece that we discuss in the paper is this notion of default equity plans. So we recommend affirmatively requiring grant recipients, such as public health authorities at the state and local level, to file an equity plan as a condition of receiving federal funds, and in the alternative, supplying them with an equity plan. So we think this is a means of inducing states to inducing them to attend to racial equity by having them file a plan that agencies that employ scientific experts and also equity experts can evaluate. As part of the CDC's response to racial disparities and COVID-19 burdens, the agency actually appointed a chief health equity officer and began specifically collecting and reporting data on COVID-19 outcomes by race and ethnicity. And there was perhaps a missed opportunity to have that play more of a role in terms of interaction with state and local agencies. The agency didn't, however, require grant recipients to commit to specific equity enhancing strategies as a condition of receiving vaccine supplies or other assistance from CDC or HHS. For the vaccine distribution, we recommended default equity plans in part because of speed, right? Default equity is kind of a starting point. States could then select the parts of the strategy that they wish to pursue or adopt the default plan wholesale. The creation of a default plan would save states time as they seek federal funds, and ensure that states at least consider implementing strategies that we are known to promote equity. But I believe it has broader relevance, even when speed is not an issue. And we can talk about this more in the Q&A if there's time, but I have examples from housing, which is an area that I've worked in. Housing has its own equality directives. It requires that localities that receive federal funds affirmatively further fair housing and engage in a process to determine what that looks like in their community. That's wonderful, that bottom-up participation, that analysis at the state and local level. But at this point, there's also a lot of known information about what promotes equity and mobility and access to fair housing. And one could flip the process and have that learning also contribute to these default equity plans. So I will end by saying that there's much more to explore here. So this is the Equality Directive model, as I say, is something that there are versions of in housing, in education, and in transit. Environment and disaster relief are areas where it could be adopted more vigorously. Obviously, in the environment has the model in that it has environmental impact statements, but the racial equity piece and the idea of doing front-end assessments is not pervasive in the environmental area. This always raises questions for people about, is this real? Is this just kind of paper enforcement? What kind of regulatory oversight and enforcement mechanisms are there? So I'm happy to talk about that. I will say that there is a lot of interest at the federal level in the kind of equality directive, a default equity plan, and equity audits, which I didn't get a chance to talk to, but can approach. Biden's, one of his first acts in office was to issue an executive order that all federal agencies should examine their own practices to see how they might better advance equity on a number of dimensions, including racial equity. So I will stop there and I will stop sharing, and perhaps we can get into the discussion.
Excellent. Thank you so much, Professor Johnson. And let me invite members of the audience to pose questions in your Zoom Q&A function. And we will turn to these now. In fact, the first question posed by a member of the audience here is asking really, Professor Johnson, if you could bring us a little bit up to date. Your paper was focused and published last year. It was focused on the early stages of the vaccine rollout. The audience member states here that data by the Kaiser Foundation suggests that the initial disparities between racial and ethnic groups in COVID-19 vaccination rates have largely disappeared, at least in the aggregate. I don't, would you agree with that characterization from the member of our audience? And if so, then the questioner asks, if this has largely disappeared, has this been as the outcome of more equity-oriented policies? And I'm going to just insert there that some of your suggestions, like the ability to do walk-in clinics and not have to make an appointment, right, eventually came into existence, right? Or was it mainly a matter of time?
Yeah. So I suspect that we'll learn more about the why. So the difference is the inequities haven't entirely disappeared. And I'm not going to pull up all the specific data, but I think Kaiser is a really good source of some of the state-by-state data. And there's really wide variation among states in terms of who's narrowed the gap and who hasn't. They haven't entirely disappeared, but they have narrowed considerably. And I don't think we yet know all the reasons why. But here's what I've read and learned from researchers in the field, and then some of my intuitions. I mean, so some of it is just predictable because of the inverse equity hypothesis, right? That as time goes on and there was more access, that this was sort of, a rush in the early stages, right? That doesn't mean it doesn't matter, because there are people who continue to die throughout all of 2021, perhaps unnecessarily. Second, I do think that there was learning in real time. I mean, some of the places that were driving a lot of infection, like in New York City, right, really changed and adjusted practices quickly. There's still a vaccine disparity in New York City, but it definitely narrowed because they started to adopt things like partnering with community-based organizations, having drop-in, no registration sites. So I think those things made a difference. I know that the data is kept separately for Native American populations, but they adopted really aggressive outreach practices from the start that I think made a big difference. So I think that's, I hope we're not just doing learning for the next pandemic, but I think that's important. The other thing, of course, is something that we're also aware of, which has been the kind of partisan divide in who's vaccinated at this point. And so, whatever was the narrative at the early stages in terms of who wanted to have access to the vaccine got clouded very much by a kind of new sort of unanticipated layer of a kind of partisan divide in who wants the vaccine or who thinks it's necessary.
That brings up another question from the audience. Here's from a member who's tuning into us from Peru. Welcome. And says it's actually astonishing to this person that having the vaccine available and free, there are still so many people who have yet to get vaccinated. Whereas in Peru, people are desperate to have their shots. Can you help this person understand, who says, never thought about the racism and the distrust behind the decision to get vaccinated? Could you talk a little bit more about what that kind of hesitancy might be deriving from?
I don't have anything particularly insightful to say about vaccine hesitancy. I mean, that's a whole area that is partly about things that I think about, which is a lot about democracy and partisanship in my other hat, but is partly about a whole history of vaccines in this country, right? But I think what I read, what I can say is, two things. I mean, one is, just to make a emphasis on what I was saying, that there were other forces that started to kind of change the narrative around vaccines, such that now we think of vaccine hesitancy that's driven by kind of partisanship and disinformation as being the kind of key issue. But early on in the vaccine, when in the COVID-19 pandemic, that was not what we were most worried about. It's not that we weren't worried about it at all. We were worried about communities that were really hard hit, not being able to access the vaccine. And so I think the person who raises this from Peru is really is raising a really good question, is raising a really good issue. But behind it, I also see something that did concern us shortly after we wrote our paper, which is, the global inequities are so much graver at this point. I mean, more market, because we have so much access in the United States to the vaccine than people do internationally. And so, that question, I think, is now the question that people who, in the larger public health community and the global public health community are attending to.
Another comment, maybe more for reaction than a question here, from a member of the audience who attributes an insight to a senior policy advisor for equity within the White House COVID-19 response team, who spoke on a panel and noted that apparently that even policies that appear to be equitable, such as make vaccines available first to those over 65 years of age, are racially inequitable if you factor in that African Americans were getting sicker at a younger age on average.
Yeah, yeah. And I think that's a really important insight. And it's something that I mean, that you can learn from. I mean, the whole methodology in public health is actually to learn, about, from these pandemics or, disease outbreaks, and use that to inform policy going forward. I think that the age question might not have been as poignant. I don't think people realized it. Some people made that recommendation early on, fairly early on, certainly in the summer of 2021, about the fact that age perhaps was too crude a category. But the thing that was really pointed out at the beginning had to do with neighborhoods, because neighborhoods, people live in them in a highly networked way that spreads the vaccine. And if you did this on the basis of zip code, and that was a strategy that New York City started to switch to, was really emphasizing neighborhoods. And I think that's one that, given my interest in the spatial dimensions of inequality, and the fact that people are sometimes reluctant to use race as a crude category, I would have looked at that. The other is just not realizing who were the frontline workers. Obviously, the healthcare workers had to be prioritized, but even within those priority categories, hospitals were very different, situated very differently in terms of their access to personal protective equipment, in terms of the load that they had, and how many people were coming in, and all of those might have called for sort of tailoring strategies in those situations. And then, of course, the next wave, I remember teachers being there very early on, which I appreciated in some respect, but I was able to take advantage of that category, and maybe transit workers or delivery workers should have had priority. Some of those kinds of questions. You have to understand the ecology of a community, and some of those, they don't all have to be things that are decided by CDC. They could also be decided at the state and local level.
Yeah, and I think those are things. The nice, your proposal about planning for these is really important, and there was time to be doing this planning. It seems like on a number of fronts, there hadn't been. We invested the research in the vaccine and the development of the vaccine, which was tremendous to get it, but we lagged on and wasted, I think, a good bit of time while that was going on, not developing better planning overall. Now, I want to shift a little bit to law, and one question begins with a premise that New York did issue an explicitly race-conscious guidance for prioritizing COVID treatments when at the outset. This is the claim here, but that guidance was met by a lawsuit from a group alleging race discrimination, and would likely be subject to strict scrutiny. So this questioner asked, how can you recommend any way to defend race-conscious equity approaches to vaccine distribution? And let me share another related question, asking about the Supreme Court and how it's approaching Title VI today, how it's likely to approach affirmative action in some of the cases currently on its docket. Does this place that the Supreme Court is at, or is likely to be at here later in the year, does it shift or alter your thinking about the promise of Title VI, in particular as it relates to vaccine equity? And just in general, how can you justify race-sensitive approaches to vaccine equity in a world that's increasingly contentious on issues of race, and where people bristle at the idea of any race-conscious approaches to equity?
Yeah. So let me answer it first as a lawyer. So one, in terms of the New York approach, know about the lawsuit. I haven't read it for a few months, but I read the complaint in the lawsuit. I also read the policy. It doesn't use race as a classification. It talks about areas of risk and mentions race. And so it doesn't say there's some allocation or quota based on race. That said, any mention of race, this is at the point where we are, can trigger a lawsuit. And I think often there are ways of attending to the disproportionate harm that that certain communities face without explicitly using a racial classification. So one of the things in the paper that we really talk about and emphasize, and is a lot of the reason I began with the spatial dimensions, is around questions of neighborhoods. And if you're going to not be able to be race conscious, certainly do some GIS mapping and see who's being affected. And I think that at least should be more pervasive in how we think about regulation. CDC has a social vulnerability index that's around a concentration of socioeconomic factors. So that's what I'd say at the beginning. I think that right now, in my view, we're in a very unfortunate place because we recognize that there is a history in this country and there is a contemporary reality of race acting independently of class in ways I really could write a dissertation about, but I don't have to because there are lots and lots of books about it. You cannot always do class and get at race. It's just not how race is operated in this country. You look at the environmental data on pollution, and lots of researchers have disaggregated it from race from income and found that race does independent work. So that means if you live in a predominantly Black community, even if it's middle class, working class, you're more likely to be exposed to pollutants. So we see those trends just throughout different sectors in education. For instance, middle-class Black children attend schools with higher poverty rates than middle-class white children. Why is that? A lot of that is because of the intersection between of schools, residential segregation and school policy. So this is well documented in the empirical literature. And yet, I think increasingly in a concern, whether valid or not, about racial quotas or making decisions solely on the basis of race, we've now moved to the point where even wanting to remedy that is considered suspect. And this is evident from a recent decision that has come out in the district court in Virginia, where even talking about caring about a racial remedy, and I think that's really far afield from where we were in the Grutter case, which is the affirmative action case that said you could consider race as a plus factor. And I think it's just very dangerous territory to be on, especially for people who are not actively advancing another place to locate, to advance equality. In terms of Title VI, so Title VI, I hope, there's, it's a statute that says that you can, it's a anti-discrimination statute, and all our anti-discrimination statutes have been interpreted at this point to allow claims of intentional discrimination and disparate impact. I think that Congress should make it explicit in Title VI that there's a private right of action, just to safeguard that enforcement mechanism, both for the intent claims and the disparate impact claims.
I think, on the kind of spatial approaches that you're suggesting, it dovetails with your recommendation on data collection and reporting, reinforces, and it seems to me, the reason why we would have done well to have more testing overall as over the last couple of years. So a lot of the, a lot of questions that might have happened about spatial clustering, we were, really just not aware of things as precisely or finely tuned as on a neighborhood by neighborhood basis, for example, without a lot of testing, right?
Yeah. And it's always hard to, fault what was going on at a time in which we were just learning so much. And I think public health authorities were overwhelmed. I know that there were very early on recommendations made that testing should be the key to, it was the key to ending the pandemic. It was the key to being able to monitor what was going on. And some people really pushed that very early on, but it was not the predominant public health strategy. But I think the other piece of that I would really emphasize that you just said is that the data gathering was really spotty throughout the pandemic, not just because of lack of access to tests, but not everyone disaggregated the data. And that's one of the recommendations that we talk about in the paper.
We've got a couple of questions about particular segments of the public, homeless and housing burden, and incarcerated individuals. Where at least with incarcerated individuals, it's clearly an overrepresentation of Black people in the prison system. But yet not necessarily a priority when it came to vaccination. How do we think about homeless or housing challenged and housing equity and incarceration when it comes to vaccine equity?
Yeah, I mean, I think the issue goes far beyond vaccine equity. I mean, I think there was a responsibility to really vaccinate people in the most vulnerable populations. And particularly, there was a lot of emphasis on people by advocates on what are the duties we owe to people who are in prison. And it was kind of shocking how people in prison were not made a priority population. So I take that as a kind of a comment. The housing and homeless issues are just worsened in every way because of the pandemic, and that's a legacy that we're going. It's just something that we're just going to have to attend to. Obviously, there's a larger kind of crisis around affordable housing even prior to the pandemic. And I think it's one of the biggest crises facing our country right now. I mean, it's affordability of housing is something I give a lot of thought to too, and most of my work is around both fair housing and access to housing, and also about the barriers to building more housing and how we can adopt policies at the federal level. They are using some of the same kind of incentivization mechanisms that are sort of like equality directives, but they're less coercive. They're really mostly thinking about using grant authority to really encourage and reward communities that get rid of exclusionary zoning and build more affordable housing.
That leads to a question that was raised by a student in Professor Ose Owusu's class, and that class is joining us. Shout out to them and to Professor Ose Owusu. The student asks, what are the housing equity initiatives that you think have worked well? I mean, can you say a little bit more about the affirmatively fair housing efforts and how they would translate into this arena?
Yeah, let me talk about, I don't know how much people know about it. Some people have heard me talk about it a lot and are very familiar with it, and other people have never heard of this aspect of the Fair Housing Act. So the Fair Housing Act, passed in 1968. I think a lot of people know that it prohibits discrimination in the rental and sale of housing. What's less known is that it has a provision that requires recipients of federal funds to affirmatively further fair housing. And there was a very specific reason that was put there. If you look at the legislative history, it actually talks about the federal government's complicity in creating a dual housing market. Just all of the the things that are now documented in American apartheid and the color of law, the federal role in creating a segregation in housing. And so what it says is we have a duty to allow opportunity in the regional housing market to promote integration. And the question is, what does that really mean? And how do you enforce that? And just to make a long story short, it's been fitfully enforced by the federal government. Mitt Romney's father was one of the people who tried to put a lot of federal teeth into it and was blocked by his boss, President Nixon, in doing that by encouraging the building of affordable housing in suburbs. I think and then most recently, there was a lawsuit in Westchester County that got on Westchester County because it was taking money and it was saying we're affirmatively furthering fair housing, but it really wasn't. And out of that lawsuit, the Obama administration ultimately strengthened the regulatory guidelines. Trump then suspended the guidelines, and then now Biden has reinstated them. So mixed record in terms of enforcement. I will say that there are a lot of jurisdictions that have done really meaningful work under AFFH, and studies that have been done on it have shown that jurisdictions that engage in the process have adopted measures such as getting rid of certain forms of zoning that excludes different kinds of, housing for low-income people and supportive housing, building housing near transit, and changing the way in which they allow voucher recipients to be able to access housing in the regional housing market. So there's a lot that can be done on that. My thing right now is that I think that the federal government, after 10 years, even though it's kind of fitful of enforcing this or having these regulations. Maybe it's not a little bit less than 10 years, but there's been a lot of learning about what's worked at the local level. And I think that, and we know a lot in general about what promotes housing opportunity. And so some of that should be mandated for grant recipients. And we should also give grants and reward jurisdictions that adopt inclusive housing practices.
Bringing it back to vaccines, since so much of the implementation and of the rollout was administered at the state and the local level, are there any states or cities that you want to hold up in our final minutes as exemplars? Any place that made it, breakthrough that should be celebrated and replicated either in the weeks and months or that or years we have left of this situation or for the next one?
Well, it's really interesting if you go back to some of the maps. We have some of the lift ups of strategies in our paper. But if you go back to some of the maps, one of the things that's really interesting is that some of the jurisdictions that have the least racial disparity are those that don't have a very large population of people of color. So I don't know which way that cuts, but they invested a lot in distributing vaccines in general. Some of the states like Vermont and Maine don't have that much of a disparity. But what I learned from the paper were some strategies. Rhode Island adopted a social vulnerability index, and there were other states that did that really early on, and so really had a neighborhood-based strategy. I mean, we'll have to still, analyze the data about how much that made an impact for them and what are the enduring consequences for that for access to healthcare. But that was striking. I think a lot of Native American communities, the outreach efforts that were done really narrowed or made disappear some of the gaps, or there was high access in a lot of Native American communities. And then I would hold out New York City, and actually there's a strategy that I actually thought was really good in New York State for countering some of the resistance to COVID policies. So let me comment on both of them really quickly. I mean, one at the state level, one of the areas that I think about a lot is the conflict between states and localities in a whole range of policies like labor and guns and things like that, and when states preempt localities. So there was conflict between New York City and New York State throughout the pandemic in terms of COVID policies. But much of the regulation was done at the state level, but they allowed regions to, or they adopted a strategy that tailored policies and responses by region, right? And so that upstate didn't have to be subject to the same rules that we were downstate. And it was data driven and it was transparent. I am not saying this is perfect, okay? Nothing was perfect, but I thought as a model, it was very good. You knew your hospitalization rates, access to testing, the death rates over 7 days. We could all go on the dashboard and look at it, and Albany or the parts of upstate New York, they didn't have to be subject to masking rules that New York City was subject to at the same time if they were having lower kind of overall averages. So I think that's a good model for a policy. Just it's not about vaccines specifically, but about building trust, and at a time where it's been sort of a very polarizing kind of issue around vaccines. And then New York City also, I think, was very good at providing a lot of information and really double down on some of the outreach efforts. I think what was really striking was the testing. Testing was very, very accessible in New York City. I think that's very parochial of me to mention New York, but I did study and look at that, and hopefully I gave a shout to some other states.
Well, this is a good way to end.
There's more in our paper on that too.
Good.
Yeah.
A nice way to end on some positive lessons learned. I'm sorry that we couldn't get to all of the questions in our time today, but I thank you, Professor Johnson, not only for working on the paper, but spending time to share it and the results of so much of your other tremendous scholarship on race and regulation and anti-discrimination law with us here today. I want to remind all the members of the audience that this video will be available of the lecture today on our YouTube channel at the Penn Program on Regulations website. You can go there and find the link to our YouTube channel. And our next lecture in this series on race and regulation will be held on March 23rd. Ming Chen from UC Hastings Law will be speaking on race, immigration, and political inequality, and I hope to see you all there. Let me conclude again with a very earnest thank you to Professor Johnson for being with us here today. This was a very important and illuminating conversation, and I'm glad we could have it. Thank you very much for your time.
Thank you. I really appreciate it. Thank you very much for having me.
Good rest of the day, everyone. Take care.